hiatal hernia is a significant enough size for the surgery to be chosen. But the number of patients you see with large hernias will still be there, and so you're not really interfering with the patients that you're currently sending for surgery. What Stretta is most important. It's safe, it's effective, it's the cost issue here in India is an issue. It's an American product, it's an American manufactured product. So we understand there are cost issues, but in terms of some of the other endoluminal options out there, it's very effectively priced, and it's an outpatient procedure. So the patient can come in the morning, have the procedure, and go once you're satisfied with their progress. So on the left-hand side, you'll see really 70% of your patient groups will still respond effectively to meds, and they'll be quite happy to stay on the PPIs. The PPIs work. Where we sit is really in this nice middle ground here, where there are about 25 to 30% of the patients, because only 5% of your current patient groupings you're sending for surgery. For those patients that don't want to go for surgery, or perhaps aren't appropriate for surgery, and whose PPI response is dropping, we do prefer there to be some response to PPIs, because if the patients have no response to PPIs whatsoever, then there may be other issues at stake that's causing their symptoms. So our advantage really is that we're extremely well studied. You know, we have now 37 clinical studies, 4 randomized controlled trials, adequately powered, showing Stretta to be safe, very safe, less than 1% complication of 20,000 cases. There's never been a fatality. Being an American company, we have to report any issues during a procedure. There's never been a stricture or a rupture of the esophagus. There's no dysphagia associated with Stretta. So it really is a very nice, safe procedure. Also shown to be very effective and durable, because we now have 3 published, peer-reviewed, published 4-year studies, 1 8-year, and now we have 1 American 10-year follow-up study showing, as I'll show in a second, a significant amount of patients after 1 Stretta procedure still off all PPIs or on reduced levels of PPIs. So the evidence that we have is very comprehensive. It's now up to 20,000 procedures. The usage globally is increasing. The studies are from all over the world, and from big university hospitals to cottage hospitals. We've got level 1 evidence. We've got medical society support in the American Society of Gastroenterology and also SAGES. And these clinical studies are showing consistent benefits from the Stretta procedure. This meta-analysis was 1,441 patients, taken only from the RCT and cohort data. So it was done by Ohio State University in the States, showing all the subjective and objective measurements you would look for as gastroenterologists, statistically significantly improved. The only one that didn't normalize, and we get this thrown at us, is that we didn't normalize the pH. We improved it, statistically significantly improved the pH, but we didn't normalize it. But you know, even PPIs don't normalize PPH, so it's, you know, we're really quite content that this is showing a very broad improvement after the Stretta procedure. 10-year, the 4-year, 3 4-year, 1 8-year from Italy, 3 from America, and what's interesting is that the results are all very similar. So it's kind of broadly similar across the board. So the register by Wolfson 2002, 558 patients, again rated symptom score and visual median symptom scores improved. The extra esophageal related GERD, again another study, 505 patients. So all these things, all these studies are available. In the back of my card you'll see an online training that's free, designed by doctors for doctors. So you can go in there at your leisure if you've got some spare time, which I know is at a premium. Then it's a free training, and it just allows you to go through the whole process of Stretta and also SECA at your leisure. A listing of some of the data. I've not got time to go into these studies in great depth. The conclusions from the multi-observational studies were very, very consistent and very similar to the randomized controlled trials and the meta-analysis. So we've got the 2 societies, SAGES initially. The surgeons were the first to give Stretta a real glowing thumbs up, and then American Society of Gastroenterology followed suit, And this year at DDW, we were in their training area, giving daily lectures and training on Stretta. SAGES was quite significant, one of the first major societies to endorse Stretta. They have a rating of quality of evidence 1 to 4 stars, and they have a grade recommendation medium and strong. They've given Stretta the highest level of quality of evidence and the highest grade of recommendation that it's possible to get. So it's a pretty strong endorsement from SAGES, the surgeons. And the American Society of Gastroenterology stated that adverse events were infrequent and typically minor. The technique appears to durably relieve GERD symptoms for up to 10 years in the majority of patients. This technique uses RF energy delivery to the distal esophagus and appears to reduce GERD by decreasing tissue compliance and reducing the transient lower esophageal relaxations. Now we've got published data now to show why that's happening, which is quite significant. So how does it work? Well, basically we're using needles to deliver heat to the muscle around the Z-line, around the esophageal gastric line. Our first treatment level is 1 centimeter cephalad to the esophageal gastric line, and then we move forward in ½ centimeter levels, doing 2 treatments at each of these first 4 levels. So the Stretta catheter has 4 needles, almost like in a cross, and these needles deliver heat to the temperature. We're looking for a target temperature of 85 degrees. So subablation temperatures. We're not looking to cause fibrosis, and we're not looking to cause scar tissue, but we are looking to cause a physiological change to the muscle. And how that muscle is affected, we've shown in a study. The fibroblasts in the muscle break down after the heat's delivered. They reform into myofibroblasts. So what we're showing is an increase in smooth muscle fiber, an increase in collagen 1, and a decrease in the collagen 3, and a decrease in the interstitial cells of Cajal, which probably explains why the transient relaxations are lowered. So we have a very simple, safe delivery mechanism. The generator is there to ensure complete safety for the patient. If the generator doesn't like what it's sensing from a needle, it will switch that needle off for that 1 minute cycle, and then it resets for the next cycle. So really you've got, it's not unusual to see needles switch off during the procedure. We probably, as an American company, are too safe. Many doctors have said that we're erring on the side of too safe. But you know, American companies hate to be sued, so we're kind of, it's safety first with us. It's very important for us, our safety record. So just in summary, we have functional improvement, we've got symptom relief, and the functional improvement includes the reduction in TLSRs, the barrier increases, the acid exposure decreases, the muscle thickness increases, and the pressure increases. And this providing the symptom relief, as well as if you're using MMS or manometry systems here, you can see quite clearly the changes that are taking place after your patients have been treated. So we are non-ablative radiofrequency. We treat 2 areas, the lower esophageal sphincter, and also we treat the internal anal sphincter, providing gastroenterologists for the first time a therapeutic option for fecal incontinence, because we're kind of doing the same thing. We're using 4 needles to reduce the sphincter compliance that allows a stiffening of the sphincter, which in the case of the SECA device, which is our second product, it gives the patients the sensation of gas or feces so they can get to the toilet on time. It's a huge problem in India, much larger than people realize, because patients are often too embarrassed to even go to their doctors about this issue. But we have now a non-surgical therapeutic option for gastroenterologists to treat fecal incontinence. So what we showed this is the Cleveland Clinic and Professor Herman's study. So they showed quite clearly in a long-term animal study that we were really increasing the smooth muscle fiber. So this is now published, peer-reviewed published data. A full copy of the study can be made available for you. And again, there's been some canine and human information to show that we're actually increasing the smooth muscle fiber in the area that we're looking to treat. So really, it's a valuable tool for gastroenterologists. ENT doctors and bariatric doctors are now becoming very excited about the possibility of using Stretta, because especially after gastric sleeve, many patients present with a really severe reflux after the gastric sleeve, and not unusual when you think they're taking a hallway and they're turning it into a doorway. The pressure is increased, and so a lot of patients, they estimate 40 to 50% of patients following a gastric sleeve have the unfortunate new symptom of really severe reflux after the sleeve.